So we're going to continue and let's get to primary T. This is point number 5 on Indra's profile. On Indra's file. We saw diagnostics first, and then pulp diagnostic, then periradicular or periapical conditions, and now we are in primary teeth. Then endodontic treatment, now primary teeth. Radiolucency at furcation. Radiolucency at furcation in one primary molar. Necrotic pulp. Treatment for radiolucency at furcation on the primary molar, which is most unlikely necrotic. Extraction. If it's a primary second, okay. If it's a primary second, yes, that has a radiolucency of furcation, but is restorable, then you do pulpectomy. If it's a primary second with radiolucency at furcation, but it is restorable, then you do a pulpectomy. If it's any other primary tooth with no furcation, you do pulpotomy. If it's a tooth that has its primary teeth with no furcation, like a primary molar, you do pulpotomy. And if it does have a furcation, then you do an extraction on a primary molar. Okay, so it's talking about the radiolucency of the furcation. If it has no radiolucency at the furcation but it's not restorable, it's a primary molar extraction. If no furcation, no radiolucency of furcation, and it is restorable, and it has root resorption, you do extraction. If there is no radiolucency of furcation, it is restorable, and it has no root resorption, then pulpectomy. No electrical pulp test for traumatic tooth. Precaution, you can do it for newly erupted teeth. So reviewing again the treatment, this decision-making tree, if it has a furcation, if a tooth has a furcation, if it doesn't have a furcation, then pulpotomy. If it does have a furcation, you have to think, is it a primary molar? Yes, if it is a primary molar with a furcation and radiolucency, you do extraction. If it doesn't, then is it restorable? Yes, if it's restorable, you have to consider if it has resorption. If it doesn't have resorption, you do pulpectomy, and if it has absorption, you do extraction. So if it's not restorable, then extract. Apexogenesis. Apexogenesis, apexification, and apicoectomy. Apexogenesis, the tooth is vital and it has an open apex. And an apexification is a non-vital tooth with incomplete apex formation. You use MTA. Example, if you have a tooth with irreversible pulpitis with open apex. Apicoectomy, root and reception. For example, failing root canal therapy when an apical position, persistent apical pathology after root canal therapy, apical fracture overextension. A root canal medication and irrigation, calcium hydroxide, MTA, zinc oxide eugenol, formocresol, sodium hypochlorite, EDTA. So calcium hydroxide is it helps preserve the vitality and continue the development, achieve apical closure because it can stimulate the formation of the apex. Contraindicated in pulpotomies in a child because it causes irritation leading to resorption in primary enamel and pulp symptomatic for the pulp will be symptomatic for the last month. So, oh, and contraindicated that pulp has been symptomatic for the last month. MTA, which is mineral trioxide aggregate, is an endodontic cement that is extremely biocompatible, capable of stimulating healing and osteogenesis, and is hydrophilic. Close apex with MTA. It has the least cytotoxicity. Again, MTA is an endodontic cement that is extremely biocompatible, capable of stimulating healing and osteogenesis, and is hydrophilic. Close apex with MTA. The least cytotoxic. Zinc oxide eugenol used for pulpectomy. Zinc oxide eugenol used for pulpectomy. Apex not closed in primary teeth. Formocresol is the most common medication for pulpectomy and pulpotomy. Will stop the bleeding because it has a formaldehyde component. Sodium hypochlorite is not a chelator, dissolves organic tissue that is necrotic. It's a disinfectant, is the most common irrigant. EDTA at 17%. It is a chelating agent, removes inorganic material in smear layer. Avulsed teeth. The most important factor for avulsed teeth is time. Hank solution is the best storage media for avulsed teeth. Two. Milk has a pH of 6.5 to 6.8. Best to preserve periodontal ligament or use saliva or physiologic saline solution. 90% of the cases of the success rate is before 15 minutes. 50% success rate, 30 minutes. Splint avulsed teeth for 1 to 2 weeks or 7 to 10 days. Do not replant primary teeth that have been avulsed. Do not replant primary teeth that have been avulsed. The failure to replant avulsed teeth, external resorption. Now splinting. Splinting in an avulsed tooth will be done with a non-rigid splint in antibiotics for 7 to 10 days. A horizontal root fracture, use rigid splint for 3 months for 12 weeks. Rigid rigid splint horizontal root fractures. For diagnosis, take multiple vertical x-rays. For an extrusion, splint for 2 to 3 weeks. For an intrusion, reposition, and splint. Endodontic lesions. A pink tooth, internal resorption. The treatment is root canal therapy. Replacement resorption when the tooth is ankylosed. Vertical root fracture. Root canal therapy, crown and pin. Most common in mandibular molars. Mandibular second, followed by mandibular first, and primary premolars are the most commonly affected. Maxillary premolars. So, mandibular second followed by mandibular first and maxillary premolars. Most common cause is condensation of gutta percha. Isolated pocket depth is a key diagnostic finding, and it's also called cracked tooth. Cracked tooth, pain upon biting on mandibular first molars. Occlusal trauma, crown that is sensitive to cold and sensitive pressure. Granuloma, root canal therapy, tooth, apical lesion after apicoectomy, still sensitive, neutrophils, plasma cells. It is non-vital. It has no symptoms. Preceded by chronic apical periodontitis. Ameloblastoma. Ameloblastoma is a benign local aggressive form from odontogenic epithelium. Multilocular radiolucency caused tooth resorption, mostly in mandible. A cyst is an inflammatory response of the period with that develops from excessive granuloma. Central fluid filled epithelium lined cavity, chronically infected tooth. Radiographically, you will find a well-defined radiolucency limited by radiopacity border of bone, of sclerotic bone. It is asymptomatic. A granuloma in cyst only differentiated. Granuloma in cyst. Cyst is differentiated. Cementoma. Cementoma, periapical cemental dysplasia. Periapical segmental dysplasia, anterior mandibular radiolucency, radio opacity calcifies vital teeth. Again, is segmentoma, periapical segmental dysplasia is shown first as an anterior mandibular radiolucency and then a radio opacity when it calcifies, mostly seen on vital teeth. The teeth are vital actually. Now, a traumatic bone cyst is not a true cyst, no epithelial lining. It is more common in young people. It's asymptomatic. Radiolucency appears, arrows, vital tooth. Globulomaxillar cyst is a developmental cyst. Lateral incisors, canine roots. It's on vital teeth. A lateral periodontal cyst is also vital. Phoenix abscess is an acute exacerbation of a chronic apical periodontitis. So we're gonna review now failures of root canal therapy. First one is cleaning of canals. Causes for failures: cleaning, accurate cleaning of the canals, poorly filled canals, lack of seal, radiolucency and fistula due to incomplete root canal therapy, inadequate disinfection, and bacterial anaerobic infection. What is the axis to root canal? So we can do root canal therapy. Maxillary central incisor is triangular. Maxillary lateral incisor, canine, and second premolar, it's oval. Maxillary first premolar, kidney shape. Maxillary molars, triangular, and mandibular molars, trapezoid. Operative. A critical pH to develop caries 5.5. The enamel starts to demineralize. Fluoride is anticardiogenic. The earliest sign in a carious lesion is the change of opacity. Three factors: caries initiation, substrate, bacteria, host susceptibility. Caries initiator, strep mutans, which is acidogenic and cardiogenic. Caries progression of decay, lactobacillus. Root caries, lactobacillus. Most cardiogenic, sucrose, because it's converted to dextrins using the enzyme glucosyltransferase. Dextrins are sticky, they'll stick to the tooth surface. Caries in children depend on the amount, consistency, and time. Remineralized enamel is harder and more resistant to acids, darker than the surrounding, rougher than tooth structure. Interproximal caries below the proximal caries below the contact, apical to the proximal contact. Early childhood caries, most on maxillary centrals and first premolars, mandibular unaffected because tongue blocks. Age at which children develop dexterity and speech, 5 years to 8 years. Diagnosis of caries. Explorer catch Defoe. Defoe is a caries detection of class 1, 2, and 3. Diagnodent detects only class 1. Okay. Decayed, missing, or filled teeth index. The quantities, this quantifies how the permanent dentition has been affected by dental caries. Decayed, missing, or filled teeth index is DMFT. DMF. The decay, missing, or filled surfaces, which is a DMFS, is a more detailed index as it quantifies how each surface has been affected by caries. The decayed, extracted, or filled teeth in is also for primary dentition, and it quantifies how the primary dentition has been affected by dental caries. So the first one is the all capitals, this one is not. And okay, the just remember the EFT is for kids. DEFT. DEFT is for kids. Decayed, extracted, or filled, while for adults is decayed, missing, or filled. So extracted versus missing. Most common caries in Hispanics. Most common unrestored caries, blacks. Most common caries in permanent teeth, white females. Most common location of caries, pits and fissures. Both two cones, both facing the continuum and enamel junction. Primary teeth, largest to smallest. The largest primary teeth is the mandibular second molar, the smallest mandibular lateral incisor. In permanent teeth, largest to smallest, the largest primary tooth is the maxillary second molar, and the smallest is also mandibular central. Oh, no, no. This one is the central incisor. In primary teeth, the smallest one was the mandibular lateral incisor. In uh, permanent teeth, the smallest is the mandibular central incisor. Burrs. We're going to see burrs now. This is a very important and boring subject, but you need to see it. Permanent teeth, largest to smallest. The largest I mean, burrs. Tungsten carbide cutting into dentin middle crowns amalgam. Cutting efficiency of carbide is more